Hello everyone. Welcome to the part 5 video of adrenocortical disorder. Here we go through the introduction, pathogenesis and morphology of adrenal gland, and also we see what clinical features can be appreciated in the patient who are affected by the Addison disease. So let's begin with the introduction. This is also known as primary chronic adrenocortical insufficiency, and this is a very uncommon disorder and that results from the progressive destruction of the adrenal cortex. And also this is not manifested until at least 90% adrenal cortex is compromised, and all races and both sexes may be affected, but if Addison disease develop in the setting of autoimmune adrenalitis, then that is more common in Caucasian and in women. So, pathogenesis of Addison disease can be seen as we know that in organ various organ disorders like lymphoma, amyloidosis, sarcoidosis, and so many other like adrenal hemorrhage. All these affect adrenal cortex. This may also result in primary chronic adrenocortical insufficiency, and more than 90% cases are due to one of the four disorders, which are as autoimmune adrenalitis or um, autoimmune polyendocrinopathy syndrome or tuberculosis or AIDS or metastatic cancers. So let's begin Addison disease in the setting of autoimmune adrenalitis. This accounts for 80 to 90% cases of primary chronic adrenal insufficiency, and this result from the autoimmune destruction of the steroidogenic cells and auto antibodies to several steroidogenic enzymes like 21 hydroxylase and 17 hydroxylase in most patients, and 40% cases of such variety of Addison disease occur as an isolated condition, while 60% present as a part of an autoimmune polyendocrinopathy syndrome (APS). And APS type 1 is caused by mutation in the autoimmune regulator gene, which are normally present on the thymus, and that function as a transcription factor and promote the expression of the main peripheral tissues, and the selective T cells which recognizes self antigens are eliminated by the mechanism central T cell tolerance or peripheral T cell tolerance. But once the function of this autoimmune regulator gene is absent, absent, then this central T cell tolerance to peripheral tissue antigens are compromised, and this will promote autoimmunity. And also autoantibodies are developed against T helper 17 derived cytokines like the interleukin 17 and interleukin 22, and such phenomena can also be seen in APS1, and we know that these cytokines are very crucial for the defense against fungal infections. So if autoantibodies are developed against such cytokines, then that will result to the reduced suppression of the fungal infection. So mean various fungal infections can be manifested, which can be as like chronic mucocutaneous candidiasis, and also this APS first can be characterized by ectodermal dystrophy, where there is abnormalities of skin, dental enamels, and nails, and also organ-specific autoimmune disorders can be seen uh, since there is mutation of the autoimmune regulators, and so this self-antigen recognizing T cells are not cleared or not eliminated, so various target organs can be affected, and if adrenal gland is affected, then that results in autoimmune adrenalitis. But and if a parathyroid gland is affected, that results in autoimmune hypoparathyroidism, and if gonads or gonadotrophy cells uh, in the anterior pituitary are affected, then that results in idiopathic hypogonadism, and also it results in pernicious anemia if RBC is affected. And similarly, this APS2 usually start in the fourth decade of life, and this is more prevalent than APS first, and it presents as a combination of adrenal insufficiency and also autoimmune thyroiditis. That means in this APS2, the uh, autoimmunity that results in the destruction of the thyroid gland as well, resulting in autoimmune thyroiditis, and also present with or without type 1 diabetes. And the features of APS first, like mucocutaneous candidiasis, ectodermal dystrophy, and autoimmune hypoparathyroidism that do not develop in APS2, but autoimmune thyroiditis is seen in APS2, and this is more prevalent than APS1. And APS4 is a very rare condition which is characterized by adrenalitis and autoimmune phenomena like gastritis, vitiligo, alopecia, and pernicious anemia. But thyroiditis as well as type 1 diabetes that are not present, and also the features of APS first is also not seen in APS4. So infection, particularly tuberculosis and those caused by the fungi, um, cause Addison disease as well, and tuberculous adenoiditis, which are from this tuberculous bacterium infection, that account for more than 90% cases of Addison disease, and often associated with active infections in their sites like lungs and the genitourinary tract, and also disseminated infection caused by Histoplasma capsulatum, coccidioids, imitis. Such infections also result in Addison disease or adrenocortical insufficiency, and AIDS patients are at risk of developing this adrenocortical insufficiency from several infections, that is like cytomegalovirus, mycobacterium, avium intracellular, and Kaposi sarcoma. And metastatic neoplasm also results in adrenocortical insufficiency, especially the carcinoma of the lungs and breast metastasized to the adrenal glands, affecting the adrenals, and that results in insufficiency. And also the neoplasms that can metastasize to adrenals are like GI tract carcinomas, malignant melanoma, and hematopoietic neoplasms. And the genetic cause to these Addison disease could be congenital adrenal hypoplasia and adrenoleukodystrophy. This congenital adrenal hypoplasia results from the mutation in the NRB1 gene that encode DAX1 transcription factor, and this adrenoleukodystrophy that is caused by mutation of the ATP binding acid subfamily D member 1. And morphology of adrenal gland that we can appreciate in Addison disease relating to the various cause of it. Like if Addison disease is due to primary autoimmune adrenalitis, then the gland is seen as irregularly shrunken, and that is difficult to diagnose within the suprarenal adipose tissues, and the connective tissues within the cortical cells, with scattered cortical cells are seen in the cortex, and the lymphoid infiltrate are seen within the cortex, which may extend to the adjacent medulla as well. And in tuberculosis and fungus disease, which results in Addison disease, uh, there we can appreciate that adrenal architecture are effaced by the granulomatous inflammatory reactions. And similarly, this Uh, Addison disease due to metastatic carcinoma present with the enlarged adrenal gland. And now we see the various clinical features of the Addison's disease. First, we see the gastrointestinal symptoms, which is the very early symptoms or early manifestation of Addison's disease, where we can see abdominal pain, diarrhea, constipation, anorexia. Then we see muscle weakness, fat loss, amenorrhea in females, and if it begins for a longer period of time, then that results in neurological symptoms as well, like lethargy, easy fatigability, depression as well, and also the person will lose weight. And similarly, the lab investigations show there is a decreased corticosteroid and ACTS level is increased, and we can see this hyperkalemia, which results in erythema. And similarly reduced sodium retention, because in the previous slide we saw that the autoantibodies are estrogenic cells which are producing this 21 hydroxylase 17 hydroxylase that might be destructed, and is this estrogenic enzymes when get disrupted from the various region, that results in reduced formation of aldosterone. So sodium retention will be compromised, and if sodium retention is compromised, then fluid retention is also compromised, so that results in hypotension. And also the chlorine level decreases, bicarbonate level decreases, and this glucose level also decreases, because glucocorticoids, that means especially cortisol level, will also be low in Addison stages, because the enzymes are also affected. So if these glucocorticoid level are deficient, then that results in impaired gluconeogenesis, and that manifested as hypoglycemia. Similarly, hyperpigmentation can be seen in at sun exposed and at pressure points like neck, elbows, knees, and knuckles. We know that in Addison's disease, the there is adrenocortical insufficiency. That means cortisol, aldosterone, and all other hormones are compromised, that are produced in a very reduced amount. So if cortisols are not produced, then ACTH level will be elevated. Similarly, the precursor of ACTH is this pro-opiomelanocortin, and this is also the precursor of melanin or melanocyte stimulating hormone. So the ACTH level will be increased in absence of this feedback inhibition by the cortisol. So once that is elevated, that will promote the utilization of those precursor, and also that will channelize that um, pro-opiomelanocortin to the formation of the melanocyte stimulating hormone, and that results in deposition of melanin at neck region, elbows, knees, and knuckles, and that is manifested as hyperpigmentation. And this is the hypoglycemia, how it develops in Addison's disease. And similarly, a patient with Addison disease presents with increased pigmentation at the buccal mucosa. Normally, such hyperpigmentation are not seen in the buccal mucosa, but patient of Addison disease may present with such things. Thank you so much.